Good afternoon, everyone. I want to thank all of you for joining us at today's event on Medicare. It's a very well-timed event. I'm Bill Arnone. I'm the Chief Executive of the National Academy of Social Insurance. And today's conversation on Medicare and health equity is part of our Academy's multi-year campaign called Pathways to Economic Security. We kicked it off earlier this year, but we're going to be elaborating on it, particularly at our annual membership meeting. For those of you who are Academy members, please register for that meeting on January 13th. You'll find out more about the campaign and, more importantly, how you can get involved in it in a meaningful way. Much of our work here at the National Academy of Social Insurance builds on a vision that was laid out by President Franklin Roosevelt's Committee on Economic Security, which led to the creation of Social Security in 1935 and really laid the groundwork for the enactment of Medicare and Medicaid 30 years later in 1965. I've read that committee report more than once. To me, it's a landmark report, and some of the words that were written in 1935 jump out at you. And the one that means the most to us at the Academy is how the committee described a program of economic security, quote, as one that must have as its primary aim the assurance of an adequate income to each human being in childhood, youth, middle age, or old age, in sickness, or in health. Now, we have had an economic security study panel deliberating over the past year to try to see how can we take a fresh look at this overarching vision, this bold vision, and make it real for more Americans today. The study panel's findings will be issued early in 2022. It'll include policy options to improve the different programs that often don't interact well, that affect economic security for millions. Again, we'll be discussing it in more detail for Academy members on our January 13th membership meeting. We're thrilled that Jim Roosevelt, who served on this study panel, is going to be joining us to moderate today's program and offer his perspective. Jim, as many of you know, has spent his entire life thinking about economic security and a big part of his career on the critical role of healthcare and contributing to it. He also understands the role of employers, the focus of this conversation, who are major stakeholders in any effort to promote economic security. Our campaign is going to bring together the perspectives of various stakeholders, including employers, as we work to strengthen the social insurance infrastructure that has truly served as the foundation of economic security for millions, but needs improvement. Before we proceed, a few housekeeping notes. First, today's webinar is being recorded and will be accessible on our website. Second, we really encourage those of you who have signed up, and we're very thrilled at the numbers that this webinar has attracted. We want you to participate in today's dialogue using the tools on your screen. Two ways to participate. There's a chat box. You can type comments in the chat box, or if you want to pose questions for the panelists, the Q&A function is the way to do that. Both of the boxes are on the menu at the bottom of your screen. And you can also submit questions via email after the webinar, and we'll get them to the right panelists and be able to continue this conversation. Just a note on the chat feature, it enables a conversation among all audience members. So make sure the recipients are all panelists and attendees. The default option would be just the panelists. But for the Q&A, those will be directed to the panelists themselves. So with that, let me thank Verrill for supporting the campaign and this event, to the New England Council and the Massachusetts Hospital Association for acting as co-hosts. And let me now turn it over to Jim Roosevelt, who will serve as the moderator. Jim?
Thank you, Bill. As you mentioned, I have served on the Economic Security Study Panel over the past 2 years, and the scope of that has focused on income security programs. With that said, those on the panel have been very aware that as you and the audience know, there can be no true economic security without health security. We've asked each of the panelists today to do a brief introduction of themselves, and I'll just mention that I do practice healthcare law and also consulting and policy from the Boston office of the Verrill Law firm. But I was previously CEO of Tufts Health Plan, which has about a 49% market share of Medicare Advantage in Massachusetts. And in the Clinton administration, I was Associate Commissioner of Social Security for retirement policy. So I've come at this from many directions. Let me turn now to the substance a bit. A 2019 article in the American Journal of Public Health found that 2/3 of all bankruptcies in the United States are tied to medical issues, including direct costs and time out of work while receiving care. That amounted to 530,000 family bankruptcies in 2019 alone. That, by the way, is a great improvement in reducing bankruptcies since the Affordable Care Act went into place, roughly a 50% reduction in bankruptcies, and yet it shows you how critical this issue is. These families are economically insecure to begin with, and our health system, rather than serving as a springboard, consumes the few resources that they have and leaves them virtually nothing. While there is no shortage of issues in the healthcare system that we might cover, today we're going to focus on a program that covers almost 64 million Americans and is doing a fair amount to improve equity in our healthcare system. That program is Medicare. And about 58% of Medicare recipients are in the traditional program, and 42% are in some form of Medicare Advantage. Recently, Medicare made headlines for the impending 2022 14.5% increase in Part B premiums. In real terms, this amounts to an increase of $21.60 for the average recipient. Although the 5.9% cost of living adjustment for Social Security will help offset this increase, those with the lowest benefits will be in the most jeopardy. We've also seen Medicare in the news lately because of postponement of cuts to Medicare reimbursement that had been scheduled to go into effect on January 1st. Those have been temporarily postponed under the legislation for dealing with the pandemic, but those also loom on the horizon. Now, shortly, I'm going to be joined by three great panelists with a range of expertise. We will discuss the implications of the premium increase through an equity lens and prescription drugs as a cost driver. We will explore what the cost of Medicare Advantage, what the growth of Medicare Advantage means for our healthcare system, and we will examine certain options to expand Medicare coverage to larger segments of the population. As we deliberate, we ask that you submit any questions you have through the Q&A function at the bottom of your Zoom window. So without further ado, I invite the panelists to join me on video and say words about each of themselves before we dive in. Zuri, why don't you get us started?
Thank you so much, Jim. I'm Zuri Song. I'm an associate professor of healthcare policy at Harvard Medical School and a primary care physician at Massachusetts General Hospital.
Hi, I'm Juliette Kubanski. I'm Deputy Director of the Program on Medicare at KFF, which many of you may know more familiarly as the Kaiser Family Foundation.
We'll get used to KFF as a noun.
Please do. Yeah, please do.
We all use KFF. Hello, everyone. My name is Rhett Buttle. I'm the founder of Public-Private Strategies and the Public-Private Strategies Institute. We work at the intersection of employers and public policy, and probably most relevant to this conversation, I also served in the Obama administration at the Department of Health and Human Services, working on Medicare payment reform.
Thank you each. Let's dive in with the implication right away with the implications of the 14.5% Medicare Part B premium increase. Who would like to lead off with a little commentary on that?
Well, I'm happy to dive into that question. I think, excuse me, I think, pardon me, I think what's very noticeable or notable about this premium increase for 2022 is the magnitude due solely to one treatment that Medicare hasn't even issued a coverage decision on, which is this new drug for Alzheimer's, Aduhelm. The cost of covering this high-priced treatment is getting passed along to everyone on Medicare, not just to the patients who may need it and who may use it, depending on what Medicare's coverage decision is. That's obviously how insurance works in terms of pooling risk, but I think it may seem to many people more concerning in this case because we're talking about one high-priced drug contributing significantly to the spike in Medicare premiums for 2022. And as I said, that has implications for all people on Medicare, not just those patients who may use this drug. So it certainly, I think, represents, perhaps a sign of things to come, but a concerning trend for 2022. That Medicare is not really in a position to deal with the cost of new treatments that are coming to market, but needs to pass them along to beneficiaries in the form of higher premiums.
Anyone else like to comment on this premium increase for looking at it through an equity lens?
Yeah, the only thing I would comment, it's a little more broad, is I think it is drawing some broader attention to the conversation on prescription drugs, which is obviously linked to what is going on with Medicare. And there's obviously conversations on Capitol Hill right now with the Build Back Better plan, and maybe should the plan pass sort of the limited provisions for Medicare for the first time to do some negotiation. And I think what we're seeing from the employer side, and it's not this easily complicated, but I often like to break things down by larger employers and small employers. And, for large employers, obviously many of them are offering their own health insurance plans, but for small employers, Medicare is actually a really important piece of the puzzle. And, as we were getting ready for this session, one of the things we were talking a lot about was the vast majority of people who start businesses are in their 50 plus, and Medicare can sometimes be an important part of that. And we're seeing prescription drugs sort of really become highlighted in the employer community. I think some of that is being driven by what's going on in the Medicare market. A lot of private plans are often looking at Medicare as well. And so this broader theme around prescription drugs, how we're going to tackle that, I think is becoming a more pressing issue for employers. Cost has always been an issue, but I think in particular, sort of how we are thinking about handling prescription drugs is being highlighted by a little bit about what Juliet was talking about.
I would just say in terms of the equity issue, I think it was already mentioned, that Medicare beneficiaries who are receiving Social Security benefits are getting this, relatively generous 5.9% increase in the COLA for 2022, and that will definitely help to offset the increase in the Part B premium for the average Social Security recipient. But, there are still people who receive relatively low Social Security benefits. So for people with relatively low incomes who are getting, an additional maybe $20, $25 in their Social Security benefit, the Part B premium increase is going to eat up pretty much all of that, leaving them with very little left to, pay for rising healthcare costs and gas and food and all the other expenses of daily life. So, so again, even though it may only seem like, oh, $20 a month, it's not that big of a deal for many people on Medicare who have low incomes, it is a big deal. And so, there is some discussion among policymakers urging the Biden administration to intervene to halt this premium increase. But, for the most part, it seems that this is a train that's left the station. And what it will really do is kind of leave beneficiaries kind of holding the bag, to deal with the fact that pharmaceutical companies come to market with high-priced drugs, and Medicare generally makes decisions to cover them without regard to their cost.
So what I think is tricky here from a political and a public policy standpoint is that it is bedrock principle that Medicare in each part, but particularly in B, has to be actuarially sound. Actuaries try to anticipate what's going to happen. Sometimes they are more conservative. Sometimes they are taken by surprise by something. So they're trying to, I think, to be actuarially sound here. What I think this really does is highlight the larger question of prescription drug pricing. We have this one example here, just as we've had other examples over the last several years of single drugs with huge price increases. And it's always a question of whether huge price increases in drugs used by a few people are better or worse than small price increases by drugs used by lots of people. It still comes down to the fact that this is the only industrialized country where there is not only no government program of pricing for prescription drugs, there is a specific prohibition on Medicare and Medicare contractors negotiating drug prices.
Right. And certainly in terms of the Build Back Better Act and the discussion around, potential changes to prescription drug policies in the U.S., there are a lot of provisions in the BBBA that could help to deal with both the fact that Medicare doesn't have the ability now to negotiate drug prices, the fact that drug prices increase, sometimes quite high rates from one year to the next. It's interesting, though, I think bringing it back to this Alzheimer's drug, it's actually an example of a drug where the provisions of the Build Back Better Act really wouldn't, unfortunately, have much of an impact in terms of this drug's price or what patients pay out of pocket for this drug. Aduhelm will be covered, if Medicare decides to cover it, it would be covered under Part B. And in the Build Back Better Act, there's a provision to allow the federal government to negotiate drug prices, but only for drugs that have been on the market for at least 9 years if they're small molecule drugs, or 13 years if they're biologics. So Aduhelm, being approved in 2021, wouldn't be subject to price negotiation until 2034 or 35 at the earliest. So, we would have several years of paying potentially billions of dollars for this medication before the price negotiation provision would kick in for this particular drug. There's also a proposal to cap what Medicare beneficiaries who are enrolled in Part D pay out of pocket for their medications. There is no cap right now on out-of-pocket drug costs under Part D, which is Medicare's outpatient drug benefit. The proposed cap is $2,000, and that would be a substantial improvement compared to the current design of the Part D benefit. But again, Aduhelm would not be covered under Part B. It would be covered under it wouldn't be covered under Part D. It would be covered under Part B, and there is no out-of-pocket cap on medical costs under Part A or Part B. So, the Build Back Better Act would provide benefits in terms of lowering out-of-pocket costs and lowering Medicare spending on prescription drugs. But Aduhelm is an example of one drug that kind of slips through the cracks. in terms of the different prescription drug proposals that are in that piece of legislation.
Now, in the Q&A, it's been asked, is the problem the drug companies alone, or does it also include the PBMs, the Medicare Advantage plans, and the opaque rebate system? How do you even begin to sort this out? Would anybody like to weigh in with an answer to that?
I would just add that there are potential important effects for Medicare Advantage plans, which touches on the question a little bit. As you noted, Jim, the increase in the premiums is a reflection of actuarial estimates of increases in total Medicare spending for the traditional Medicare program. The traditional Medicare program is an important input into payments for Medicare Advantage plans, specifically the benchmark payment amount that the government offers to potential MA entrants. MA plans have been known to select enrollees based on a host of clinical or demographic characteristics. And if the benchmark payments for MA plans were to go up as a result of total medical spending for traditional Medicare beneficiaries going up, there's an opportunity for MA plans to probably seek larger profits from selecting against a diagnosis such as dementia or cognitive impairment. That would impose potential important equity concerns for the entire population.
Anyone else have a view on that?
I mean, I think fingers can be pointed in lots of different directions as far as, the issue or the problem with prescription drug prices in the U.S. Jim, as you pointed out, we don't have a, central regulator of prescription drug prices or, as in other countries, taking into account safety, effectiveness, and cost in making decisions about whether or not drugs will be approved. So the FDA looks at safety and effectiveness, but, cost is not a part of that equation. And so drug companies do have, a lot of discretion, a lot of power in terms of, where they will price their products. PBMs have come to play an important role in our prescription drug marketplace because prices are so high, and employers and other payers use PBMs to help them sort of sort through prescription drug pricing, make good deals, get rebates, make formulary coverage decisions, and people might be concerned about sort of the opaqueness of rebates, but they do kind of help keep costs in check for payers, and that gets passed along to enrollees in the form of lower premiums or less high kind of premium increases from one year to the next. But I think fundamentally we have higher drug prices in this country than in any other country. And so we've got a fragmented system and sort of a lot of different problems related to prescription drugs as a result. The Build Back Better Act is trying to deal with some of those problems, but I don't think there's one piece of legislation that could, kind of come in with solutions to all of the concerns that we have in this country with regard to prescription drug prices, whether it's manufacturers' ability to set prices wherever they want or, opaque rebates that people don't understand. It's kind of a puzzle with lots of different pieces that we're sort of trying to fit together as best we can.
Yeah, I was just going to build on what Juliet said, and I think it is a puzzle, and there's probably I'll use the term like responsibility for all pieces of the puzzle to think about sort of solutions going forward. But I wanted to add in and sort of tying this back to equity, which I know is the point of this, is we've been doing a lot of survey work of employers throughout the pandemic. Obviously, the way that employers are thinking about the future of benefits is changing, how they think about sort of, their interactions with the market and with Medicare. Obviously, that is all changing as well. But one of the most fascinating things is we've been breaking a lot of our survey research over the last few months down by race and ethnicity to really get an understanding of how Black business owners, Latino business owners, Asian business owners are thinking things, as well as their white counterparts. And it's fascinating across all of the issues with the pandemic, whether it's access to capital or employee retention, healthcare cost is the number one issue. And we actually saw that rise. And it's super fascinating because coming out of COVID, we heard about so many things, so many of the challenges, and employers are continuing to face challenges as I would say the future of work is changing. But this issue around healthcare costs some of this being driven by the conversation. But we saw in particular people that are owned, people of color who own businesses were impacted much more greatly by the pandemic. And they cite healthcare costs as their number one issue. So for a lot of them, they're not necessarily in the mechanics of the conversation we're having today about what's driving cost in Medicare and what's driving cost in the system, but they are feeling it as the end user, as we still have a really important, as employers still have a really important role to play, obviously, in the private health insurance market.
So to my mind, we won't actually have a rational discussion on this subject until we develop a mechanism for more transparency, a greater ability to assess the cost of research, the cost of failure, which failure is important in making progress, the cost of manufacturing, the cost of marketing, the cost of distribution, all of those things. We really have, in the public discussion, no clear data on each of those components. Particular manufacturers or particular research organizations may know their own data, but it's not publicly available. And that's, to me, the great constraint on having a real discussion about this.
Can I just say, I think this is just informed by my time working in the government. I think data and transparency is such an important tool, but it has to be then backed by powerful advocacy. And so you can put so much tremendous data and transparency out, and that will have a certain effect on the market. But the reality is in the policy landscape right now, research is just one tool that we have to bring to the table. And I really think, obviously I see things just through the world of employers, because that's the world I'm in. There's so many other important constituencies. AARP represents such an important constituency, for example, and their voice needs to be at the table and others. But until we get to the point where constituencies are really pushing policymakers to sort of challenge these issues and using the data as an advocacy tool, that for me is going to be the real change point. We have a moment here, as Juliet was talking about, with BBB to begin the process. And she kind of was going into the process of, well, it allows Medicare to negotiate, doesn't it? The reality is like, it's not, it would be a really important change, but it's not as drastic, I think, as some people think the sort of change that we need. And so in some ways, it's an incremental step. And I think sort of an important step that BBB could provide sort of on this path and this journey that we could learn a lot from. But until folks get activated, and I think particularly the employer community raises their voice and say, these are some issues that need to be tackled around cost that will have an impact on the overall market. For me, it's not just the data and research, which is an important tool, but it sort of has to be backed by that voice to really push policymakers to put the sort of guardrails that we need to make the market work more effectively. And also, I think that will promote greater innovation in the pharmaceuticals as well.
Now, to shift gears for a minute, a separate trend within Medicare is the growth of enrollment and spending under Medicare Advantage plans. As we suggested in the introductory remarks, enrollment has doubled over the past decade, and that's based on KFF data. What do any of you think that this trend means for beneficiaries, for employers, for providers, and for the Medicare program as a whole?
Well, I think one thing to recognize is that the Medicare Advantage program does provide an important source of choice for Medicare beneficiaries. Voting with their feet, they've shown us that Medicare Advantage plans are attractive for a number of reasons. There may be lower monthly premiums. There are, in fact, a number of zero premium plans in most large counties across the country. both Part D and Part B premiums can be lowered all the way down to zero by the plans. There's also additional benefits such as vision, dental, and hearing coverage offered by many MA plans that traditional Medicare doesn't offer. So it's an important source of choice, but on the flip side, we should also recognize that every dollar spent on the Medicare Advantage program may not be as high value of a dollar that is currently spent in the traditional Medicare program. Not to say that the traditional Medicare program isn't without low value care or wasteful spending itself, but plenty of rigorous academic papers have shown that the Medicare Advantage plan, on average, Medicare Advantage plans tend to spend either a little bit less on inpatient care or on total medical spending, while at the same time being paid a little bit more because of the risk adjustment that is offered to MA plans, where risk adjustment based on diagnosis codes can garner the plans a lot more Medicare dollars than does a similarly risky beneficiary in traditional Medicare. So there are certainly trade-offs to the Medicare Advantage program for taxpayers, for the Medicare program. And as far as for beneficiaries themselves, most of the work has shown that quality of care is roughly comparable, similar across traditional Medicare and Medicare Advantage.
So I would also say, one of the original goals of the Medicare Advantage program was to, leverage the efficiencies of managed care to reduce Medicare spending. But the program has never generated savings relative to traditional Medicare. In fact, our research suggests, and plenty of other research suggests, that the opposite is true. That in fact, you spend more, the Medicare program is spending more for a beneficiary in Medicare Advantage than if that beneficiary was in traditional Medicare. As Zuri noted, the extra benefits that Medicare Advantage plans offer do improve coverage for beneficiaries who choose Medicare Advantage plans. And these extra benefits have definitely contributed to the substantial increase in Medicare Advantage enrollment. But I guess I'd also say, these higher payments for Medicare Advantage enrollees have also led to higher Medicare spending overall. And that feeds into higher Medicare Part B premiums, taking it back to our original question. And those higher premiums are paid by all beneficiaries, including those in traditional Medicare. So, given that we're expecting Medicare Advantage enrollment to continue to grow in the future, as more Medicare beneficiaries enroll in these private plans, the differences in Medicare payments between traditional Medicare and Medicare Advantage will lead to even higher Medicare spending and even more generous benefits for beneficiaries in Medicare Advantage relative to traditional Medicare, which I think raises some important questions related to equity in terms of what beneficiaries in Medicare Advantage plans receive versus what is not covered under traditional Medicare. And it also contributes to challenges facing the Medicare Hospital Insurance Trust Fund, which is an issue that we haven't talked about yet. But in terms of the solvency of the trust fund, if we're accelerating Medicare spending, we may see the solvency of the trust fund even sooner than is currently projected, which, the trustees have just told us 2026 is the year that the Part A trust fund will be depleted. So we're not that far away from 2026. So, on the one hand, Medicare Advantage offers beneficiaries choice and extra benefits, and on the other hand, it represents higher program spending than we would see otherwise. And as Zuri noted, it's not entirely clear whether we're getting that much more for the money that we're spending.
Briefly adding on to, sorry, Jim, just briefly adding on to.
No, you go ahead. I'm sorry.
No worries. Just briefly adding on to Juliet's point, one of the key issues in the Medicare Advantage market is the lack of competition between Medicare Advantage plans. as Juliet noted, the fundamental principle of using a private market to administer Medicare benefits is competition based on prices or quality. And we do measure plan quality today, and there are various incentives for quality. But on the issue of pure total medical spending underlying costs for the plans, the first problem is that the government does not, and taxpayers do not have a very easy or transparent way of knowing the true costs of Medicare Advantage plans. And what that does is it obscures our evaluations of competition based on spending or cost. In many Medicare Advantage counties or many markets across the country, there are relatively few Medicare Advantage plans. Many MA plans gain very large risk-adjusted payments, partly because of the favorability of risk adjustment. And it's not clear that right now the market mechanics are set up even for very robust competition. The most concrete example of that is currently when Medicare Advantage plans submit a bid to the federal government, they are bidding against a traditional Medicare administered spending benchmark. They're not bidding against each other. In a traditional market, sellers compete against each other. And yet in this so-called market that's been designed to act like a market, mechanically it's been designed such that private actors compete against a federally established benchmark. That dulls down or takes away a lot of the competitive forces that might otherwise be intrinsically part of this market.
Thanks for that. In the chat, the question is being raised about how many beneficiaries are enrolled in and even automatically enrolled in global and professional direct contracting. Can anyone speak to that? I'm not really familiar with that mechanism.
I don't actually have an answer to that question. I will just say, I know that the CMS, Medicare, is very interested in getting beneficiaries, whether they're in, sort of managed care, Medicare Advantage arrangements, or whether they're in traditional Medicare, aligned to accountable care organizations, alternative payment models that provide that same sort of coordinated care that beneficiaries are, in theory, getting when they're enrolled in a Medicare Advantage plan. I know CMS's goal is to have as many beneficiaries as possible, 80 or 90%, I think, beneficiaries getting care through one of these kind of alternative payment models where there is greater care coordination. And that could certainly be beneficial to beneficiaries who don't want to sign up for a Medicare Advantage plan, but could benefit from that type of care coordination. But I'm not aware of an estimate of exactly how many beneficiaries outside of Medicare Advantage plans are currently in those types of arrangements.
Direct contracting, right? Okay. All right. Thank you. Let me just turn for a minute to the overall coverage question. In 2020, the Academy issued a study panel report on options to expand Medicare coverage. The report highlighted three approaches: lowering the eligibility age, expanding to Medicare for all, or a Medicare buy-in option. Lowering the eligibility age has received the most attention from the Biden administration, but it is not yet actually on the table for discussion in Congress. Could you all discuss the equity impacts of lower eligibility age and the employer impacts and the trust fund impacts?
Well, I'd be happy to set up this discussion for my colleagues, and in part thanks to your colleagues, Jim, I've been allowed to share a couple of slides. So let me just pull up a couple of slides to share a bit of background. This is a simple diagram that illustrates what might happen if one were to move the eligibility age of Medicare from 65 to something like age 60, for example, noting that there are roughly about 20 million people in the country in that age span. Breaking this down into three simple buckets. The first is that you would be pulling the 5 oldest years below age 65 into the Medicare program, presumably, or may pull them if they enter Medicare. And that has a variety of risk pooling effects on the under 65 market. So for employers and for Medicaid, the average level of sickness of that population, if the 5 oldest years were to leave the pool, would certainly go down. And you might have also a significantly number of fewer uninsured people within that age band. But the second category is a set of financial effects that are not often as discussed. For example, the federal government would actually receive more taxes from employers because of the tax exclusion of employer-sponsored health insurance that would go away for that 5-year age band. The federal government would have to offer less federal subsidies for the ACA marketplace because there would be fewer people in the marketplace at an older age that would demand more subsidies. Medicare would actually receive a few more dollars in terms of Part B premiums as well. And the Medicare program itself, including MA notably, would have a healthier risk pool because now you're adding the 5 youngest years of the age distribution to an otherwise older program. And for states, they would receive a big relief because of the shifting of dollars into the Medicare federal program as opposed to the state budgets, which obviously have to be balanced and cannot be funded through deficit spending. And the third category here is that Medicare would actually have to spend a little more too on Social Security spending to the extent that moving the eligibility age would change retirement decisions. So with this sort of as a basic drop to the financial implications for various state and federal entities, I wanted to touch on the equity aspect of this by showing results from a recent study led by my colleagues at Yale, which looked at the effect of entering Medicare at age 65 today. When we looked at non-Hispanic white populations and non-white populations, notably Black Americans, Hispanic Americans, and those of other racial ethnic minority groups, it was clear that as folks walked into the age 65 discontinuity, the share of uninsured Americans decreased, but it decreased more for non-white populations than for white populations, so closing the disparity in access to coverage. In the share of patients without a usual source of care, that disparity closed as well. As you can see here, the drop at age 65 was larger for the non-white than the white population. Similar story for the share of patients unable to see a doctor because of cost. That drop at age 65 due to Medicare coverage was larger for the non-white population. And importantly, the share of people who reported being in poor self-reported health decreased also to a larger extent among the non-white population than the white population. And so what this taught us was that it looks like Medicare has an important and sizable effect on healthcare and health disparities as far as self-reported health at age 65 through this regression discontinuity design. And when we looked at the various states and plotted them, it was clear that states that showed a disparity in insurance coverage prior to folks entering Medicare were the states that were more likely to have a larger reduction in that disparity once people entered Medicare. This relationship across states was fairly compelling in illustrating the uniformity of Medicare's effect in closing health and healthcare disparities. And finally, on the issue of dental coverage, which traditional Medicare has to date not covered, this is ongoing work with several colleagues at Harvard showing that relative to medical insurance here in the blue, which increases at age 65, dental coverage actually drops off at age 65 as people move into Medicare. And this motivates a lot of the current discussion, or is consistent with the current discussion about whether Medicare should be expanded to cover vision, dental, and hearing, as opposed to just hospital and physician coverage and prescription drugs. So let me stop sharing and turn it to my colleagues.
I guess what I would say, I mean, Zuri's slides point out very powerfully, I think, the effect on Medicare in terms of bolstering financial security and economic security and health security among Medicare beneficiaries, kind of taking it back to the very start of this conversation. So, you know, it's clearly an important source of financial and health security for people on Medicare. So policy discussions about lowering the age of Medicare eligibility might have, you know, a relatively small effect in terms of covering people in that age, that 60 to 64 age group, because most of them already have other sources of coverage. But it could definitely improve access and affordability for millions of people. Zuri's analysis also points out there'll be, some cost shifting, shifting the burden of healthcare spending largely from employers to the federal government, and lowering the cost of coverage for people with employer-sponsored insurance while increasing federal spending, which obviously has implications for Medicare's financing sustainability. Ultimately, there's lots of sort of policy decisions that haven't been made, policy details that haven't been specified in terms of, what type of premium and cost sharing assistance would be provided to newly eligible adults. Would they be covered just like, 65-year-olds when they become eligible for Medicare? Or would there be, other sort of financing mechanisms in place? What type of benefits? Would they be able to sign up for Medicare Advantage plans? There are a lot of sort of policy details that just have not been a part of the discussion, I think in large part because this particular proposal really doesn't have a lot of traction at the moment and is probably not likely to gain much traction, at least not in the near term.
Yeah, and I would just add on sort of the more political angle. I think, they've done a good job of sort of highlighting some of the employer, opportunities and challenges around this, particularly in the large group market. We've actually done some polling in the small group market about how small employers feel about the policy idea in general. And it's really interesting, as we know, there's not a mandate for small employers to offer health insurance anymore. We did see after the passage of the ACA more small employers take up coverage, but a lot of small employers just aren't able to offer coverage even with the shop. And so a wide variety of their employees are, often going to the marketplace if they're able to get coverage. And as I mentioned before, increasingly we see people who start businesses and the people who work for those businesses be in the sort of 50 plus age range. And so we've seen an openness to some of these ideas, for example, like lowering the age range. And this is just sort of on opinion-based polling that we've done of small employers. So, there's generally strong support for Medicare. People feel like Medicare works. They feel like it's a good option. They actually have gone as far as to say they feel like it's supported their ability to be an entrepreneur which is good. We want to start new businesses. We want more entrepreneurs in our country because we know that's where job growth comes from. But it's also interesting that many of them who do have employees who maybe have tried to struggle with the small group market could see options like lowering the age as an opportunity to help grow their businesses by providing potentially some new options for some of their employees.
I'm going to pick up a couple questions from the Q&A function now. One is, with the number of Medicare enrollees expected to break 80 million in the next 10 years, is there any concern about cost shifting toward employer-based private insurance premiums and out-of-pocket payments as hospitals and I would say other providers try to negotiate higher commercial rates to offset the increased payer share of Medicare patients who are traditionally higher utilizers with lower reimbursement rates compared to commercial payers? Would you have a reaction to that?
Sorry, I didn't hear the full question. Could you give it to me again?
Yes. With Medicare enrollment expected to pass 80 million over the next 10 years, is there concern about cost shifting on premiums and out-of-pocket payments to private employers to make up for the larger number of people and lower reimbursement rates of Medicare?
So I could see it being a definite possibility. As I was talking about sort of earlier, the private market is constantly watching what is happening. Medicare is the largest health insurance program in the world. And so the private market is often constantly adjusting or matching, or sort of, I should say, looking at what Medicare is doing. As far as what we're hearing directly from employer groups, employer sort of advocates, this isn't necessarily top of mind for them in that moment. Some of that might be because, they've been focused on other policy priorities, particularly around, taxes and revenue. But we are starting to see more interest sort of in the last few weeks in employers getting engaged on these issues, but not a ton sort of at least on the public policy advocacy side to the point where folks are sort of raising this in a substantial way.
Moving to another question from the Q&A. What incentives, if any, should Medicare enrollees have to select plans, whether traditional or Medicare Advantage, that on a risk-adjusted basis provide lower cost coverage of higher quality? For example, should Medicare enrollees be given the opportunity to pay less per month to enroll in lower cost, higher quality plans versus higher cost on a risk-adjusted basis and lower quality plans, so as to put pressure on the plans and their providers to lower costs and improve quality?
Currently, Medicare tries to do that. It tries to do that by paying higher quality MA plans a larger share of the difference between their bid and the federal benchmark. And what that results in is a larger rebate given back to the MA plans. With that larger rebate, many MA plans use it to lower Part B cost sharing and Part D cost sharing often to zero. So in that sense, quality is supposed to, in one way, translate into a more attractive plan for beneficiaries. To what extent beneficiaries make their plan selection decisions based on that one premium or the Part B and the Part D premium combined, as opposed to the additional coverage that we mentioned, is not yet fully understood. But I think a better way that potentially the federal government could incentivize competition among plans at the outset so that prices for beneficiaries and total spending for taxpayers can be lower in aggregate is to simply make the market more competitive. Have the plans compete against each other on price, have the bids compete against each other's bids across plans and insurers, and at the end of the day, set the federal payment for the benchmark level of an average risk beneficiary for an average plan to be something that's derived from the competition on prices from insurers themselves. Right now, that benchmark level, again, is not determined by how low insurers are willing to bid, meaning how few of Medicare dollars they're willing to accept to participate in Medicare Advantage. Right now, it's a federal benchmark based on traditional Medicare spending. So to the extent that we can shift that aside and move towards a system where the plan's own bids determine the benchmarks that the federal government pays, we will likely see a little more competition inherently in the marketplace, which should translate into more attractive plans for consumers.
So this really goes to your earlier point about Medicare not operating as a normal market right now.
Can I also add on that point? Right now, a lot of Medicare Advantage plans are zero premium plans, and they may not all be the same in terms of quality, but from a beneficiary standpoint, if they're choosing and seeing that, I can get all these extra benefits for no premium, I'm going to sign up for this plan because my friend recommended it. It's not at all clear whether they're actually using Medicare's star rating system to compare plans and make decisions based on sort of overall quality ratings. The other thing that I think is important to note is that our research suggests that most Medicare beneficiaries, once they choose a plan, they stay with that plan. They don't go through the annual process of comparing, evaluating their options, and switching into a different plan. So this marketplace is very sticky. And I think the plans know that. And so beneficiaries aren't really operating like perfect consumers because they have 50 plans to choose from on average in a lot of counties. And that is, I think, by any standard, an overwhelming amount of choice. So it's probably not much of a surprise that most beneficiaries aren't willing to engage in this comparison shopping process on an annual basis because the sort of mental burden of doing so is just really hard to overcome.
Well,
so I think I think until we can get to a place where it is both a better marketplace in terms of plans competing against each other on price, and also getting beneficiaries to, want to or be better able to engage in the process of comparing plans, we may not get the sort of efficient outcomes that we desire.
Yeah,
Ironically, I'm sorry, go ahead, Zuri.
Sorry, Jim, just very quickly following on Juliet, and Rhett may have a comment on this. Employers, I think, have an important role to play in directing retirees into the Medicare Advantage plans they believe are best for their previous workers. There are a couple of mechanisms for doing this. One of them is called seamless transition, where employers at age 65 or upon retirement can transition their workers into an MA plan that looks and feels and is designed kind of like their commercial plan under age 65. And it's an opt-out program rather than an opt-in, such that employers will be able to shift workers onto MA plans as long as workers don't opt out within 60 days after receiving a postcard. Unless those rules have changed, that is one mechanism where employers have, you might argue, a responsibility, but at least an opportunity to help direct their workers into what they believe to be higher quality plans for whatever industry or types of workers they have, if we believe that workers themselves are not well equipped or don't have the opportunity to make that selection.
Yeah, as far as I know, the rules have not changed, and we have seen a lot of players take advantage of that. One of the challenges we've seen is there's actually a gap with some employers about actually, fully understanding that they have the opportunity to do that. At the same time, we're seeing, especially sort of in a, endemic world or post-pandemic, whatever we're living in, more people are turning to their employers for these sorts of decisions, even beyond sort of healthcare decisions. So, we're seeing the employer become more of a trusted value and resource. And I think there is an opportunity here to encourage more employers to think about playing this role.
So ironically, residents of many larger counties have more choices than they can comprehend, whereas there are smaller counties where there are very limited choices. That is another question about the structure of the program. I do know that from both survey research and focus group research, it is absolutely true that the greatest decision-making factor for most new enrollees is what they've heard from their friends. That plan is good. It took care of me when I needed it, and so on. And it's I think odd but true that there is not any really good data on whether or what percentage of enrollees pay attention to star ratings. When I was at Tufts Health Plan, we made a great effort to have 5-star ratings across all of our offerings, and we still think that was worthwhile, more for what the quality of the offering was than for as a marketing tool. So we're getting toward the end of our time here. Are there any comments that anyone else would like, any of the panelists would like to make, just so we haven't left you hanging out there? All right, I'll take that as a tribute to the moderator for having everyone heard. Thank you for really good insights and great commentary and discussions. Zuri, Juliet, and Rhett, been a great discussion, and I'm going to turn it back to Bill for some closing remarks.
Well, thank you, Jim, and let me echo your thanks to our panelists. This is very stimulating, insightful, and quite timely. Just a reminder, this recording will be available on our website probably beginning of next week. So if you have colleagues who were not able to attend, you'll get an email and you can forward it to them so they can benefit from today's discussion. I want to thank again Verrill, the New England Council, and the Massachusetts Hospital Association for co-hosting today's event. So thank you. Thanks to all of you who joined us and for your participation. There'll be more information about the Academy's campaign events in the near future. We'll be releasing our new report, Economic Security in the 21st Century, in mid-January. We also have a COVID-19 task force that is looking at what we call it's called a policy translations working group. How did social insurance, including Medicare, respond to the COVID-19 pandemic? What lessons have we learned from this terrible ordeal? And most importantly, how can we prepare for the next catastrophe in a more proactive way and not a reactive way, which is the characterization of most of our response to the pandemic. So this report will be issued sometime in early 2022. So please stay tuned for that as well as another example of the Academy's work that does touch on Medicare. With that said, I hope all of you find the time to have a meaningful holiday season. Stay safe, stay healthy, and we look forward to seeing you again in the new year. Once again, thanks to all of you and our panelists.